part of the series, we'll be discussing on common pediatric endocrine emergencies. A 3-month girl baby was brought to us with genital ambiguity since birth, failure to thrive, recurrent vomiting, an infant demanding frequent feeds yet losing weight, and the urine output was told to be adequate as per parents. On ER assessment, child is tachycardic but with preserved perfusion. Blood pressure is normal for age, chest is clear, saturation is 98%, and the blood sugar is 45 mg per deciliter. On further assessment, child's weight, length, as well as head circumferences are below third centile. On genital assessment, there is clitoromegaly, well-formed scrotum with rugosities, but no palpable testis. On basic investigations, we find hyponatremia, hyperkalemia, and metabolic acidosis, but renal functions are preserved. This is a typical scenario where we need to consider adrenal insufficiency. Steroidogenesis pathway from cholesterol occurs in adrenal cortex, and through a series of steps, the mineralocorticoids are formed from zona glomerulosa, glucocorticoids are formed from zona fasciculata, and androgens are formed in the zona reticularis and are later activated in the peripheral tissues. If there is a defect in any of these pathways, then formation of mineralocorticoids, glucocorticoids, or androgens may be affected. Congenital adrenal hyperplasia occurs when these enzymes are defective. When they are defective, the adrenal glands cannot make enough cortisol and aldosterone. The pituitary gland releases excess ACTH in order to try and stimulate cortisol production. This excess release stimulates diffuse enlargement of adrenal glands, leading on to adrenal hyperplasia. There are several enzymes which can be deficient, leading on to congenital adrenal hyperplasia, common being 21-hydroxylase deficiency. It can present as severe or classical forms or as non-classical forms where some amount of enzyme activity is still preserved. The common lab evaluation done while suspecting CAH include glucose at bedside, electrolytes and liver function, and arterial blood gas when there is ambiguous genitalia. A pelvic ultrasonography and karyotyping is also recommended. The confirmation of diagnosis is done by a random level of cortisol if it is less than 10 microgram per deciliter in non-acutely ill, and if it is less than 18 in acutely ill, indicates adrenal insufficiency. Remember, a single low value does not definitely confirm the diagnosis. If the suspicion is high, we need to do ACTH stimulation test where the cortisol is tested at baseline and 1 hour later after administration of ACTH. A change of cortisol less than 9 microgram per deciliter suggests congenital adrenal hyperplasia. The treatment during the acute phase include management of hypoglycemia, correction of fluid deficit with increase in maintenance fluid up to 2 times, hydrocortisone in stress doses, and fludrocortisone may be needed. In long term, one need to give glucocorticoid replacement with hydrocortisone and keep monitoring for iatrogenic Cushing syndrome during the therapy. Mineralocorticoid replacement with fluorocortisone acetate is also needed, and these patients need plasma renin activity in order to monitor the adequacy of treatment. Most of these children need double dosing during crisis and other stressful conditions like infection. Surgical evaluation for genitoplasty may be needed during the later stages. If you like these videos, kindly subscribe to the channel for more updates.